I'm Myanca Rodrigues, and I will be talking about my project on comparing approaches for drawing conclusions from a network meta-analysis of effectiveness of opioid substitution and antagonist therapies for patients with opioid dependence. Opioid use disorders are the general term given to a group of disorders which characterize problematic opioid addiction. Patients with OUDs are often treated with opioid substitution and antagonist therapies, or OSATs, which include agonist or substitution-assisted therapies like methadone and buprenorphine, antagonists like naloxone and naltrexone, or agonist-antagonist combinations such as Suboxone. The effectiveness of OSATs on managing clinically relevant outcomes for patients with opioid use disorders are unknown. Therefore, there exists a need to evaluate the relative effects of these interventions through a comparison of multiple treatments, also known as a network meta-analysis, to provide hierarchical estimates. Meta-analysis, or NMA, is the statistical technique that is often used to simultaneously compare multiple interventions. Despite their widespread use in evidence-based medicine, there is a long-standing issue, however, on how to present and rank the interventions in NMAs in order to facilitate clinical decision-making. So in our project, we first conducted an NMA to compare OSATs for the outcome of treatment retention in randomized control trials assessing patients with opioid use disorders, and then used NMA outputs to rank interventions using three commonly used methods. Trials included were full-scale, parallel, or multi-arm in design and assessed adults with opioid use disorders. These trials compared any OSAT versus another OSAT, placebo, or waitlist usual care or psychotherapy arm, and examined treatment retention, the number of patients remaining in the study at the end of the follow-up period, and this is shown to be both a clinically and patient-important outcome in prior mixed methods and qualitative research. We then used systematic review methods to select studies and extract data with pairs of reviewers and conducted a random effects frequentist NMA with Stata statistical software in order to estimate which intervention increased the odds of treatment retention. We assessed the certainty of both direct and indirect or NMA estimates using the grade working group approach and considered risk of bias, inconsistency, imprecision, indirectness, and publication bias. We then ranked treatments using three approaches. For the minimally contextualized method, we contextualized the relative effectiveness of interventions using both statistical significance and grade assessments regarding the certainty of evidence. The NMA odds ratio, along with its 95% confidence interval, was used to sort interventions into two categories: least effective treatments that demonstrated no difference relative to placebo, and most effective treatments which were superior to the reference or placebo intervention. If any intervention in the most effective category was found to be superior to at least another intervention in this category, we considered in a hierarchical category 3, which was termed among the most effective, while those which remained in category 2 were termed as inferior to the most effective but superior to the least effective. We then divided each category into two groups as per our grade ratings: low or moderate or high certainty of evidence. We then transformed the odds ratio into a risk difference, which was an absolute effect measure, in order to partially contextualize interventions into categories based on the magnitude of beneficial effects or clinical significance. We used the NMA estimate for the risk difference of each intervention relative to the placebo in conjunction with decision thresholds to assess whether treatments conferred a large, 50% or higher, moderate, 30 to 49%, small, 10 to 29%, trivial, 9% or lower, or harmful effect, which was an effect in the opposite direction than intended, on our outcome of interest. As there is no consensus on endpoints, these thresholds were determined in consultation with our clinical collaborators. We used absolute treatment effects and did not take the 95% confidence interval into consideration when classifying interventions. Within these 5 groups, we then identified the interventions according to the certainty of evidence and made our level of certainty explicit for each comparison. For the rank heat plot approach, we considered the cumulative probability of each intervention being the best to categorize them using the surface under the cumulative ranking curve, or SUCR values. SUCR values range from 0 to 100%, and the closer this value is to 100%, the higher the likelihood that a therapy is among the top ranks. We input these values into the online rank heat plot tool to create a circular visual aid, and SUCR values were transformed into 3 colors, red, yellow, and green, that respectively correspond to the probability that each intervention was the worst, intermediate, or the best for a particular outcome. "53 studies assessing 12 interventions were included in our NMA for treatment retention. Here, our league table compares every intervention against every other intervention, and each estimate is also color-coded as per the grade assessment of certainty. And so here you can see that we have a great deal of low certainty evidence or poor quality trials. So the minimally contextualized approach had dihydrocodone, heroin, and methadone combination therapy, and methadone alone as among the most effective treatments, and clonidine among the worst. So here we have the partially contextualized approach, and we can see that it also has similar conclusions for interventions that rank the best, like dihydrocodone and heroin and methadone, and the worst, clonidine. And the rank heat plot as well has very similar conclusions to the partially contextualized approach. However, in contrast to the minimally contextualized approach, both these approaches rank methadone only moderately, whereas the minimally contextualized approach ranked it as among the most effective intervention. So first, the clinical findings from our study are consistent with prior literature in terms of the interventions which rank the best and the worst. Additionally, Suboxone and methadone ranked at least moderately well using the 2 contextualized approaches, which is reassuring given that they're recommended by current Canadian practice guidelines. So our study definitely has limitations. We have a low quality evidence base owing to the small sample sizes and short follow-up times of trials. Additionally, we were unable to explore other patient-important markers of treatment success, such as reduction of criminal activity, due to the few number of studies which reported these outcomes. Statistical significance, clinical significance, and SUCR values. These different approaches to rank treatments may potentially impact clinical decision-making, and this is what our study has shown. The rank heat plot method does not consider the quality of evidence, which is especially problematic when the majority of trials have a high risk of bias. The partially contextualized approach has some merit in its focus on clinical significance, but uses arbitrary cutoff points to determine beneficial effects. We do want to caution that the minimally contextualized approach also has limitations. For instance, sole focus on statistical significance without regard to precision of estimates, so the width of the confidence interval, for instance, was wider for dihydrocodone and heroin and methadone due to the few number of studies that analyzed these interventions versus the confidence interval from just methadone. So 1 study versus 34 studies, and this should also be taken into consideration. But overall, we do suggest the use of the minimally contextualized approach to rank interventions for this clinical population, but have provided some degree of caution overall for ranking. I would like to thank my supervisors and the MEND lab. Thank you very much.